articular cartilage injuries, while they've been classified typically under sports medicine, really occur, I think, far more frequently as a result of high-energy trauma. They frequently involve young people, although my definition of young is rapidly changing as I get a little bit more middle-aged. And we have more and more people who are getting a little bit older who really want to stay active. And so the question is, what do we do for these? It's a trauma injury frequently because when patients are restrained in a motor vehicle, the knees are flexed, and so the femoral condyles particularly are really exposed. And that is for sure where the most common site of injury is the femoral condyles. However, tibial plateau damage does occur, and when it does, it presents some unique challenges that led me to really not have great options until recently. And what I'm going to talk about today is I hope, a great option. I think it's too early to declare that yet, but maybe going to be a great option. The challenges are, of course, the meniscus. It's in the way. And then access to the articular surface. With the femoral condyle, we can flex the knee more, and you get access to the vast majority of the condyle. But with the tibial plateau, between the meniscus covering parts and then the flat surface, it's very hard to get at big parts of it. Even getting access to microfracture can be tough in some areas. And when we're talking about articular cartilage injury, a great analogy is often made about potholes. And you can see all potholes are not created equally. So you've got a nice, well-shouldered pothole there that doesn't look very big, although we don't really have any reference to tell. But it doesn't look that big to me. And that's one that you might be able to just leave alone, and cars can drive over it and not really do a lot of damage. Or at most, maybe throw a little gravel in there like microfracture or something. On the other hand, this pothole, if you just do what many people do in medicine, which is fill that hole, and you ignore all of this, my prediction is if you came back and scoped that knee a year or two later, that would look beautiful, and this would all look terrible. And so you've got to recognize that it's very different. Than this is a gravel road where there's more dirt than cartilage or stones, and that's a whole different set of problems. And so we have to recognize all are not created equally, and you have to recognize the whole injury. So these are articular cartilage examples of my potholes. This guy you'll see at the end, and you'll see what we did, but he's got grade 4 changes there, but also extensive grade 4 changes here, and that creates a little bit of a difficulty. So do they work? Well, in case anybody didn't get enough sleep last night, I can give you the answer right now, and then you can snooze for the rest if you want. And the answer is we really don't know yet. This is really a new area. The first one I did of what I'm going to show you is exactly 7 months out because she just came back to clinic this week. So in humans, we don't really know. But we're moving toward the concept, potentially, of a biologic unicondylar knee. And the animal work is a little bit preliminary, but moving forward pretty nicely. The human cases are very preliminary. So we do know that osteochondral allografts work. You can see examples here of that's where a trochlea got done, and that has to be done by hand if you're going to do that, cutting it right now at least. You can do large areas of the patella, and then this is what you'll typically see on the femoral condyle, where we'll typically do a circle and then overlap. That's called the snowman technique, although it's an upside-down snowman. But and then on the dog you can see. Now the problems with these that I don't like as well as what I'm going to show you is this area right here and right there. When you've got these circles, you don't have perfect fill, and you're leaving some areas that are concerning. This is one of mine that I did one of those, and you probably can just barely make it out. It's right here. And this is one, I think that was 7 or 8 months out, and I had to scope the knee for a separate issue, and it was just really looking beautiful. And this patient, not surprisingly, was doing extremely well. They aren't always that way, but this is a specimen, and in many of the stains I'll show you, basically green is good and red is bad. So this is cartilage cells that are alive, and then there aren't live cells in here, although that's the bone, and it's supposed to look that way with this stain. So you can see the cartilage survived really well and has filled that hole very, very nicely in that one. So that's a histologic example of those nice-looking specimens. We also know that meniscal allografts work. You have to get the indications right. The techniques can be challenging, but they do work, and they're fresh frozen or cryopreserved. When you take a look at the evidence that's out there, in most of the studies you'll see significant improvements in almost any score that you can name. You can see in the pressure-sensitive film models here, an intact meniscus, it's spreading out the force over the knee, and blue is good and orange is bad. When you do a meniscectomy, you can see you concentrate all the force in one spot, and that leads many patients to develop significant osteoarthritis there. And down here at the very bottom, you can see an allograft, and it's not quite as good as that one, but it's a heck of a lot better than that. Laterals do better than medials. You do need to treat all the pathology, and that's where people get into trouble, where they don't treat the articular cartilage if there's an injury there as well. They'll just do the meniscus, and that doesn't work well. But overall in this operation, in the literature, about 90% are completely satisfied. 95% would do it again. And it's about a 75% 10-year survival. And I think we can do better than that if we move back toward fresh grafts rather than frozen. Some of the problems for the tibial plateau have to do with sizing, access, the fact that you often have damage to both meniscus and articular cartilage, and even if you don't, what are you going to do with the meniscus? And then the problems of getting integration of bone to bone, cartilage to cartilage, and meniscus to heal to the capsule. One of the big problems is preservation. So currently fresh grafts, whether it's articular cartilage or if you were trying to do a fresh meniscus, with the articular cartilage, you've got about 28 days of preservation where you float them in a solution after they've been harvested within a day or so of death of the donor. And enough chondrocytes stay alive for about 28 days that you can transplant them. Right now, about 80% of donor grafts get thrown away. They never get matched, and that's part of why they're so expensive. So step 2 then is, once you've identified the problems, can you solve the problems? And this is where this one's really one slide out of line. This is where we're starting to do a in vivo model using actual animals first, and starting to figure out how do you put it in, will it work in a non-benchtop situation, et cetera. And this was at the beginning just with 2, trying to figure out just the simple steps of how to do it and will it stay working. And you can see here with the cell viability that this is meniscus, and that's day 63, and you can see it looks a lot alike, pretty green. And this is the articular cartilage day 0 and day 63, and again, you can see that it stays alive very nicely. We also can check a metabolic assay, because that's really what we want to know is the tissue still metabolizing? And 1,000 is the cutoff that we think we need in order to keep the specimen alive enough to transplant. And you can see actually it hits a lower end around the time we typically transplant them these days. And then with this preservation system, it actually recovers from the shock of being in the transplant solution is a little bit better later. When we check these tissues, what we find is there's no significant difference in many of the things we can check over 63 days. We've actually taken some now out to 90. Proteoglycan content, water content, meniscal tibial articular cartilage, cell viability, Young's modulus, stiffness, tensile strength, all seem to be really well preserved over at least 63 days. And again, we've done some individual specimens up to 90. So the third thing then is the animal model, and that's where the slide earlier with 2 is the start of testing the concept in vivo. And this is where you start to work out, okay, exactly how are we going to do this? Do we need cutting guides or jigs, or do we just freehand this? Exactly how do we work around the different tissue obstacles in the way to where we can start to work on putting it in? And then we work through the fine points of doing it. You can see there you've cut out part of it, and you've got a big empty space. There in an animal model is the damaged, and then what you're going to put in its place. Here's putting it in, and dogs are very much less challenging than humans as far as getting it to work. So you can just put in K-wires and cut them off, and it actually heals very rapidly and does very well. So that's working that part through, and then you follow it later, and you can see with histologic specimens months later that indeed the tissue's alive still, it's functioning, it's viable. The animals had lameness scores, etc., that suggested this was really working well. So at that point now, we've shown that it can stay alive and that the tissue acts like it should. Now you need to apply it to real-life canine patients. So that's what Jimmy Cook's interest is he's a practicing veterinary orthopedic surgeon. So he has a big advantage. He doesn't have to deal with as many regulatory agencies as we do. And this is one of his patients, Buddy. And Buddy's an athlete. Buddy is a field champion dog. And Buddy had torn an ACL and then rapidly degenerated. And dogs, when they tear ACLs, often the knee goes downhill very quickly. So Buddy came to Mizzou after 4 different surgeries for a last hope. And you'll see here in the water treadmill, hopefully, there we go, that Buddy is not willing to put any weight on that left hind leg. You can see his ribs sticking through. Buddy's not happy. And his owner was actually, if we couldn't do anything for him, he was going to put him down because he was doing so poorly. This is Buddy's knee, so you see a reason why. Now, most of you are probably like, where's the knee? This is the tibial plateau. This is the one femoral condyle that has some cartilage left, and this is the other one. And you can see there's the one that has some cartilage. That's the other femoral condyle, and that's the tibial plateau, and lack of menisci. So you can see why Buddy was not doing well. This is what was done. It was a graft that was preserved 52 days. You can see a lot of live green cells, even though it's 52 days. And again, animals will tolerate things humans won't. So this is a whole condyle With humans, you really need to think thin, and I'll show you that in a second. But they're doing both meniscus, did an ACL, the whole thing. And this is Buddy at 4 months. And Jimmy's since renamed this a Stannard test because I said we need this test for our trauma patients. But you can see Buddy was willing to bear weight on that left leg, and we'll move on because Buddy's going to go again in a second. And then this is Buddy at 2 or 3 years out, and he was back in field trials and successfully competing and winning. So you can see just a complete change. So Jimmy's got it to where it works in his patients. Now can we apply it to human patients? And that's what we're just starting to do. So this is that knee that I showed you a minute ago, just a different view. And you can see that his meniscus is trash, his tibial plateau, he has a substantial area that's down to bone back here. It's a little dark, hard to see. And he's got a femoral condyle lesion. So we did a fresh femoral condyle graft, and this was all the way down to bone. But you can see we've got a little bit of that pothole phenomenon I told you. This isn't exactly normal. And that's part of the problems. We replaced a couple of areas, but this we didn't do like the tibial plateau, and this I think we need to develop to where we do. But on the tibial plateau then, we started to measure after opening and think thin. So the error I made early in my career was nice, big, thick graft. Easy to fix in, you can plate it, but the problem is then you're getting only nutrition from the synovial fluid, but you're getting nothing from the blood. If you go thin, you can get nutrition from both sides and keep that articular cartilage alive. So then I do a lot of meniscus transplants. So I used the same system and basically cut myself a trough as close as I could get to the cruciate ligaments without taking them out. And started cutting and did it just under fluoro guidance. Be very careful here because there are some structures in the back, especially on that lateral side, that you want to be very, very careful of. And then eventually worked it out. And that's the removed specimen. You can see that doesn't look so hot. There's not a lot of articular cartilage, a little bit right in here, but pretty ugly specimen. So it fit, and that's what we're going to put in its place, and that sure looks a lot more inviting. Again, I'm having to do it all by hand right now because we don't have jigs, but again, think thin, very thin. And then now don't tap the cartilage, but I'm able to tap from the side just on the bone and get that to kind of snug up. Now it looks like I'm doing what Jimmy was able to do with his dogs, but I'm not. I eventually put in some little 2-7 plates, and I don't really know how much we need because it's a big cancellous bone surface. I don't know how much we really need to fix it with, but for now I've done that. This is a 7-month patient. I just want to show you. This is after multiple procedures. She'd had a tibial plateau. She had an area that was just trash, and you can see it looks terrible there. And she was doing terrible. She looked a lot like Buddy. She was depressed. She'd gained 40 pounds, was really doing badly. And finally, she thanked me in clinic this week that I didn't tell her at the time she was my first patient, but she became the first. She became the first one we did this on because she was just doing horribly. I didn't tell her till this week. This is her now, and that's what it looks like. And she's lost 40 pounds. She looks like a whole new person. So this is 4 or 5 cases so far, so I still tell you we don't know. But what's the near future? Finalized container design, because that preservation system has been translated to MTF. They licensed it. But we need to finalize the container design and then start storing full-size human specimens. And then we'll need to do some outcome studies that we'll do first, and once they work as we believe they will, then get them out on the open market. Develop guides so we don't do too much freehand. And what do I see this potentially for? Well, post-traumatic OA for sure, potentially, like that lady I just showed you. Maybe a primary treatment for very selected fractures, but it would be a limited number as a primary treatment. And then maybe a stage reconstruction for severe fractures where you know you're going to fall back on this because it was so bad. So that's the kind of things we're working on right now. Do they work? This is the guy at 5 months out that I showed you a minute ago. And you can see that sure looks encouraging at the moment. The bigger problem area is that femoral side. You can see the curve match wasn't right, and this is where he's bearing his weight, but still, I don't like that. Whereas when you do the whole compartment, it just looks really, really nice. And so I think that's the route we want to keep steering toward. Right now, it looks very encouraging in the very limited number of folks we've done. Might be a great option for younger patients, such as myself. But bottom line is, we'll see. But it looks encouraging, but I still have to tell you, we don't really know because it's a little early to totally buy off on this. Thanks very much.
So I'd like to spend a little bit of time now talking about periprosthetic fractures and focusing really on the distal femur. Some studies estimate somewhere between 0.3 to about 5% of patients who have a total knee will have some sort of a periprosthetic fracture. There's a series from the Mayo Clinic looking at their joint registry where they had almost 20,000 patients and found about a 1.3% fracture rate. The distal femur fractures are much more common than the proximal tibia fractures or than the patella fractures. Now the number's on the rise. Why is that? Well, a lot more total joints are going in every year. They're going in younger patients. People are living longer. There's more revision surgery. And the fractures around the revision total knees is more common than on the primaries. One study even had a rate up to about 38%, which is seemingly pretty high, but there's clearly variation, and it's something we need to consider and will only be a bigger problem, it seems like, moving forward. So what are the risk factors? A lot of these fractures occur just like other fragility-type fractures from a low-energy fall. Much more common with osteopenia in females with advancing age. Things like chronic steroid use, inflammatory arthritis. These are different conditions that all seem to be a risk factor for fracture. Osteolysis, including infection and wear, and a stiff knee are also risk factors for having a fracture around your total knee. Here's the one that's become a little bit controversial, I think, and I don't know in everything I've read what the right answer is. As a resident, I learned notching was a problem, a risk factor for a fracture, period. Then you have some articles, this one in 2005 seemed to get a lot of attention in that there was a series of over 1,000 patients with 2 fractures in spite of about a 30% rate of notching. For those not familiar, just this area here. And the rest of the literature is a little bit vague. So some studies say yes, some studies say no. In the lab, it seems to make a difference. So I think it's probably safer practice just say try and avoid notching, have good technique, and hopefully that'll help decrease the risk. So how do you evaluate a patient? Well, what you need to consider is what is this implant? Is it loose? Was a revision already planned? Is this somebody who was on the books for next month and happened to have the unfortunate issue of having a fall and a trip and now having a fracture? Is there any bone in the distal segment? And overall, what is the patient like? How is their health? What is their activity level? So history is really important here. Were they having pain? Any signs of infection? What was their motion like? Was this a stiff knee? These are all important in the decision-making process. I think you gain a lot of information from the plain x-rays. AP lateral and even oblique can be very useful in looking at the bone stock, the quality of the bone, how much bone is really in this distal segment, which is really what comes up over and over again in the decision-making process. A CT scan can be useful if you can't get the information from the x-rays. Definitely not needed, but in some cases it may help you if you feel like you need more information. There's several classification schemes for classifying these types of fractures, but here are the key points. Where's the fracture? How high up the shaft does this fracture extend? Is it displaced or is it a crack that's barely visible? What is the bone stock and what is the stability of the prosthesis as it exists? I thought this was probably one of the better reviews that I read in reading several things, particularly to give this talk, and it's a review article from 2012 by Johnson in The Knee, and it's really a nice overview as to an algorithm and a review and a guide to management of these injuries. And I think this is a nice sort of summary slide, a little busy, but it can sum it up pretty easily. You have this supracondylar periprosthetic fracture. When you have a loose femoral prosthesis, where you see on the right side of the slide, you really need to start thinking about revision components. When you have a well-fixed prosthesis, it gets a little more complicated. If you have non-displaced fractures, in certain patients, one can consider non-operative management. Displaced fractures, it really comes down to what's that bone stock like distally. Do you have enough bone to consider fixing with any of the devices that we have available, or do you need to consider a revision? And I think that's the basic overview of how we make our decisions in what to do in addressing these fractures. So non-operative management. This is really reserved more for the non-displaced fractures, for very poor surgical candidates, really bad bone, other issues, limited ambulation, often managed with a hinge brace or a cast brace. These non-operative management was definitely done in the past and can have some pretty real complication rates in terms of non-union and malunion. Numbers 20, 23%. I saw numbers in the 40s and even 50%, depending upon what article you read. And high revision rates or need for other surgery eventually with dissatisfaction at the non-union or the malunion. Just an example, one of my partners took care of a woman in her late 80s. This is her bone. You can almost not see it. She had this fracture, was a very limited ambulator, was treated non-operatively, and here are x-rays at 6 months. So it can be done successfully, but it's the right fracture in the right patient, and that's important to put those pieces together. So if you choose to fix, what are our options? I think these are sort of the mainstay options that we have. Conventional plating, which was sort of the tried and true. Now, intramedullary nailing, locked plating, and external fixation. I've put in white the IM nailing and the locked plating because those really seem to be the treatments of choice now if we're talking about fixation, with much better results than conventional plating. And compared to external fixation, again, better results that may be a little less patient-friendly and a lot of concern about infection with external fixation, given the fact that you have arthroplasty right there. So this was a study from Tom Large, a fellow who was here a few years ago, from his time in Charlotte, where they basically looked at conventional plating and locked plating. And you can really see the gist of their findings was that locked plating had better outcomes in terms of motion and radiographically in terms of alignment. And that theme seems to come up in several of the other reviews. There's one systematic review that I found that has from 2008 with about 415 cases in 29 series. And they tried to look at this whole topic and really didn't come out with that strong statement in terms of finding, except for a few. One, this nice table here looking at relative risk, basically comparing non-operative treatment and conventional plating with nailing and with locked plating. And basically it looks like locked plating and nailing have better outcomes in terms of measurement of non-union and secondary procedures compared to conventional plating or non-operative management. They do go on in the article to talk and try and compare nailing versus locked plating, and there are some differences between the articles, but given the power and everything else, really can't make definitive statements as to what's better, nailing versus plating. So what should we do, nail or to plate, if we're going to choose to fix? Well, if we're going to plate, we probably should use lock plating, and I use the word plating here, and moving forward, that's what I'm referring to. There really are no great studies on this, as I said. Mostly small case series, retrospective reviews. Seems like maybe in some of the series there's a higher non-union rate for the locked plates compared to the nails. That was sort of hinted at in that systematic review, but really their conclusion was that there was no difference. And there are a few studies which do state that there are some higher non-union rates. Excuse me. And so this one here, it was a more recent study, a retrospective review of 52 patients, which is probably a big study on this topic, looking at the nails versus the plates. The retrograde nails is column 1, and lock plates column 2. Look, very small numbers of patients, slightly higher non-union rate in the lock plate group, and the rest of the complications as you see. However, there's other studies that look at their series of lock plates with 100% union rates, and it's great when you have small numbers, you can boast 100% success rates. And these are just 3 that showed 100% success in their treatment of these fractures with lock plating, and bringing up the question of maybe there's better fixation in the short distal segment. So what's the advantage of a nail? A nail is biomechanically has some advantages, minimal additional soft tissue disruption, better union rates. You have to make sure that your implant is an open box design so that it will accept that, and that there's got to be enough bone for distal locking. So how to be successful? Make sure you have your fracture reduced, and then you can place your nail, and you need to make sure that reduction is right on both the AP and the lateral views. You may need an open reduction, and you need to make sure you have adequate bone for distal locking fixation. I encourage use of long nails. While this is not a periprosthetic fracture, the same thing can be seen and is seen with periprosthetic fractures. With short nails, you just introduce a problem a little higher up. So if you're going to be there, it may be worth considering if it's an option. So why plate if the nails work so well? Well, sometimes there's situations where you have to plate, or maybe you believe the plates are better. Sometimes a nail just won't do. You can't get a nail in because of the structure of the total knee, the geometry. You have a very short distal segment, or maybe you want better fixation, or in an interprosthetic fracture, something like this where you really can't put a nail in. So you have to look to plates for that. They can be done in a minimally invasive way. You just need to do it that way. It's important to do it right, to get your alignment right, and to limit the soft tissue stripping. There's lots of choices with screw options, and I'll talk a bit more about them as they go. Locking screws are probably better than conventional screws, although, nothing wrong with augmenting a lock plate with conventional screws if you need to get around a prosthesis for additional fixation. A little bit about evolution of the plating. Here we have our basic periprosthetic fracture about the proximal aspect of the joint. One of the earlier plates really used a lot of unicortical screws. That's how it was made. That's how we started doing a lot of these. Get the alignment right and use unicortical screws. There has been some research to show that bicortical screws may be more advantageous in the osteoporotic bone, and a lot of the systems have evolved to allow for that to be used as well. You've got a comminuted fracture, a little more complicated than metaphysis, still some bone to allow for fixation. Bridge plating is a great option. Get your alignment right, minimally invasive, bridge plating, adequate fixation proximally and distally goes on to heal. But never forget, some of these are a little bit more like your routine fractures. If you take away the total knee component, this is a very simple fracture pattern, which you may not want to go ahead with bridge plating. And this one may be more amenable to real reduction with lag screw fixation and neutralization plate. So again, understanding your fracture is important to optimize what you want to use for fixation strategy and implant placement. So use long plates, consider bicortical screws, get the fracture reduced, and limit your soft tissue stripping. If you can't get fixation, revisit your plan and think about what you need to do next. Also around here, we're a big fan of trying to get screws in instead of cerclage wires. I think it's a little bit better for fixation. Sometimes you need them to augment, but it's something to consider. If you don't try getting the screws in, you'll never know that you probably still can. When do you replace? Fractures when the prosthesis is loose or when there's really no bone distally. And that's just something to consider as another option about revision surgery for these folks where really your fixation is going to be inadequate and it's going to be doomed to fail. There's lots of options, including hinge prostheses, tumor prostheses, and custom implants are all written about in the literature and have had very reasonable success. It's a good alternative, especially for pain control, may allow for a lot earlier weight bearing, does have high complication rates, both medical and surgical, but that's really not that different from the open reduction internal fixation group in terms of potential complications with non-operative management and trying to offer the best solutions. In terms of outcomes, again, there really are no good studies looking at either fixation or revision arthroplasty. Some small series all showing reasonable results with some higher complications in terms of medical or surgical complications from the routine primary total knee population, but both are probably better options than conventional plating or non-operative management. Patients have moderate satisfaction scores, but again, I think it's important to remember where we're starting from. So in summary, for these fractures, it's really important to make your decisions based on the fracture location, the comminution, the bone stock, the stability of the implant, and the patient factors. Nailing and lock plating both have reasonably comparable outcomes based on the literature that we have at this time, and it's important just to pick the right patient and the right fracture. Revision arthroplasty remains another alternative and is very a good choice for loose prostheses or situations with very limited distal bone. It's critical, like with other fractures as well, but it's really critical that you plan appropriately and know your options and are prepared even for intraoperative decision making if things don't go as planned and you can't get the fixation you need. The goal is to get stable fixation, to get people moving, maybe not weight bearing so early, but at least up and about with stable motion to get them up and get them going and moving forward. Thank you.
I am going to give a talk on lateral approach for the severe valgus knee. For total knee replacement in severely valgus knees, your preoperative considerations include the patient's deformity and their motion. What kind of implant are you going to use? How much constraint are you going to use? Soft tissue balancing, and then post-operative care. And I'm going to argue that this lateral approach can actually make your soft tissue balancing and ultimate function better than through the standard medial parapatellar approach. So this is a busy slide, but it's really the crux of my talk. So this is relative advantages and disadvantages of each of these approaches. So we're all familiar with the medial parapatellar arthrotomy. I think it's, what probably 99% of total knee replacements are done through. But for the severely valgus knee, where your soft tissue contractures are all on the lateral side of the knee, the medial approach is actually a relatively indirect approach to addressing that deformity. It results in lateral displacement of the quadriceps patella tendon mechanism, which is really the opposite way of where you want it to go. In some sense, it's enhancing the pre-existing deformity. If you subsequently have to do a lateral release anyways, which you typically would, you could argue that patellovascularity is compromised. There's some evidence, not great, but some evidence that this may result in increased rate of patella fractures. Patella maltracking is common after knee replacements with a valgus knee, and you're further compromising the medial soft tissue structures, which, as we'll see, tend to already be very attenuated. On the other hand, the advantage of this lateral arthrotomy is that for the lateral soft tissue contracture, it's a direct approach. It results in medial displacement of the extensor mechanism, which is actually where you want it to go. Patellovascularity, at least theoretically, can be preserved. Patella tracking should be addressed through the approach, at least more than doing it through a medial approach. And the medial soft tissue structures are protected, and you can still imbricate them through that lateral parapatellar approach. One of the downsides is that the patella tendon is at risk. It's one of the reasons that the medial parapatellar approach is the standard approach. So what is the problem? On the lateral side, with the severely valgus knee, you have contracted lateral structures. It's the retinaculum, patellofemoral ligament, even the perineal nerve. I think we all know that's at some increased risk for a valgus knee, particularly if there's a flexion contracture. There are lax medial structures, so the MCL in particular is usually quite attenuated, deficient, or even functionally absent. And then the bony deformity also tends to be on the lateral side, and so it's deficiency of the lateral femoral condyle and then usually the lateral tibial plateau. So preoperative assessment, you have to look at range of motion, flexion contractures, what is the coronal plane deformity, and is that valgus deformity passively correctable? The other thing you can't forget, in the axial plane, if you look at your merchant view, where is that patella sitting when that knee is flexed? And you can see here that this severe valgus knee, this is somebody that's already had previous surgery, multiple incisions, attenuated medial structures. It's even a little hard to believe that the medial collateral ligament is at all competent here, and then this patellar sitting out laterally. So this is sort of the classic deformity that you get with these knees. So my preoperative workup is just basic radiographs. So standing AP, lateral, notch, and merchant views. And again, you can see this patella sitting laterally. And then if you really want to take a sophisticated approach to these, if they have this patella maltracking and these severe contractures, you can consider scanograms, which you can't get at all hospitals anymore. You can get individual x-rays and piece them together, or you can use the scout film from your CT scan. And sometimes, as I'll show you in a minute, you even want a CT scan to really look at where your tubercle is, you know, what are the components of the axial plane rotational malalignment. So implant considerations, PCL sparing versus PCL sacrificing versus a constrained or CCK knee. And then often you need stems and augments because you're going to be addressing the deficiencies of the lateral side, and potentially even bulk allograft, although that's a little controversial. And I'm going to continue to argue that if you use this lateral approach, you are more likely to get reasonable soft tissue balance and more likely to be able to use a less constrained implant, which we all know contributes to longevity of the knee replacement. So this is just a slide just showing some of these options. These are the standard sorts of augments that we use for our components, and this is using bulk allograft. You can see here, this was for a massively deficient lateral femoral condyle, though that was after a revision knee. So the way this was first described by Peter Kebelish, it was a Z lengthening, and the way it evolved is that it's really now a little more equivalent to coronal plane lengthening when you're dealing with contractures internal rotation contractures of the shoulder. And so I'll show you some of the components of that in a second. The release can involve Gertie's tubercle. You can take that down with an osteotome and even use screw fixation later on. You can peel it as you do with typical lateral tibial plateau fracture and just let it stick back down. Or you can even use a suture anchor. And I'll show you again in a few slides a little more detail about the approach. Other intraoperative considerations, the valgus angle of the bone cut. It's sort of a fine balance. It's obviously easier to put your components in with more valgus because you're counteracting those contracted lateral structures, but then there's also a tendency for that knee to end up in more valgus and to put more stress on the medial structures. Assessment of femoral rotation. It can be difficult if you're missing most of your lateral femoral condyle. I'll show you a slide in a moment, but it's all the landmarks that we typically talk about: Whiteside's line, the intercondylar axis. If you have a relatively intact tibia, you can do gap balancing off of the tibia. When you're approaching it from the lateral approach, you can have a standardized approach to releasing the structures. And that's typically iliotibial band, LCL, popliteus, and the posterior lateral capsule. You do them as needed. And on the medial side, and this is pretty uncommon, you can do advancement or imbrication of the medial collateral ligament. And this is a slide showing it being done on the femoral side. You can also do that on the tibial side, particularly if that anatomy is easier for you to work with. And so this is just showing femoral rotation. Again, Whiteside's line, the transepicondylar axis, and you can see this is not dramatically deficient compared to some of these knees that we operate on, but if you just use this posterior lateral femoral condyle as your reference, you're going to massively internally rotate the femoral component. So you just have to be cognizant of the bone loss. So in terms of determining your transepicondylar axis, which is often the best reference that you have left here, you may have to do a little bit additional soft tissue dissection. And on the medial side, you have to remember that there's a sulcus between the superficial and deep origins of your deep MCL. It can be somewhat hard to palpate, but that's the center of your medial epicondyle. And the center of your lateral epicondyle is just the most prominent portion of that epicondyle that you can palpate. So you often need augments laterally here, which implies stems. You need the additional stability when you fix your component. And certainly if you need the additional constraint of a condylar constrained implant, you'll also need stems. If you're uncertain, it's, I think, best to go with less constraint, but use implants that can later on accommodate that more constrained polyethylene component. This is an example of a, I think, obviously Mcl deficient knee. So this is probably the one role for a hinged implant with the severe valgus knee. I think some people would argue that perhaps you could reconstruct the medial collateral ligament, particularly if you had a good sports partner who was willing to do that with you. But I think most total joint surgeons would say that given the lateral contracture there and the wide gapping of the medial side, this is one where you would basically replace the ligaments. So there are some downsides to this approach, and again, instability, which I think is more a function of the fact that you're dealing with a very, very complex knee that's tough to balance to begin with. Loosening of your implants, it's very controversial as to whether it makes a difference if you cement your stems versus well-fixed, press-fit, cementless stems. You often see radiolucent lines with either one of these approaches, and again, it's not entirely clear if those are clinically significant. As I talked about earlier, recurrent valgus deformity, one of the reasons that you don't want to keep going up on the valgus on your femur to compensate for those tight lateral structures. Wound healing problems, patella stress fractures, and osteonecrosis, although it's pretty uncommon with the lateral approach. I would argue the same thing for patella tracking problems. They still exist, but less common with this approach. And then perineal nerve palsy. You can injure the perineal nerve directly with the lateral approach, or you can have traction injuries to the perineal nerve as you straighten out the knee. Post-operative rehab protocol is essentially the same. If I do a tibial tubercle osteotomy for exposure, I may limit their flexion to 90 degrees, at least for 2 or 3 weeks. You have to decide if the deformity is really severe. You may want to have the patient wake up already with their knee splinted for a few days in a flexed position instead of waiting for them to wake up and seeing that there's a traction palsy. Aggressive range of motion, although you can modify that if you're protecting an MCL reconstruction. And unless you use bulk allograft, and even if you do, you usually weight bear as tolerated. So this is just a case showing the benefits of this approach. And so this is I think you would all agree, severely valgus knee. This was not entirely passively correctable. It measured to somewhere about 25 degrees with also a 15-degree flexion contracture. And so this is just showing you how you do this lateral approach. So obviously you use a lateral parapatellar incision. I actually don't want that incision to overlie my lateral retinacular incision, so I'll make it even usually a little bit more lateral than that. And you're basically doing, in effect, a coronal plane lengthening, which I think I can show you better on actual intraoperative pictures. So you're going through your retinaculum, superficial retinaculum, basically pretty much right adjacent to your patella. And then you're sliding over more laterally, and you're going through your deep retinaculum and synovium a little more posteriorly here, or more laterally. And you're also preserving, as I'll show you on my next slide, the fat pad, because that can essentially be used as a tissue expander to help with your exposure. And so this is after the arthrotomy, and this blue line I just used to ink out what was the lateral retinaculum. And you can see these clamps, Alice clamps or cokers. You can see that it's actually holding the synovial, quote unquote, deep retinacular structures. And so in the end, when you close this knee, my arrows actually aren't projecting quite right, but you can see this line right here. That is the lateral retinaculum. So I've just let it slide posteriorly or slide posterolaterally. It's not part of your closure distally, although back up over the quadriceps tendon, you have a normal closure. And these sutures actually show the fat pad and the synovium being closed to the residual retinaculum along the lateral edge of the patella and the patellar ligament. So you can see how far posteriorly this edge of the retinaculum actually is after your closure, and that's how much of a release you get here. And so this is that patient's knee. You can see we're trying to figure out femoral rotation. And these are the post-operative films. And so you don't see a post here. And so we put in we actually have a augment here. So laterally on the distal femoral condyle, there was an augment to take care of that deformity. Because of that augment, we use stems. And the stem also lets me go back at some point if this knee wasn't quite as stable as I thought it was going to be intraoperatively. These stems permit me to go back and actually convert this into a constrained knee just by changing the polyethylene. You can see there's no metal. In the system I use, there's a little metal pin reinforcing or screw reinforcing the polyethylene on their constrained poly. This is just a posterior stabilized tibial insert. And the other thing I would add is that when we had this knee open, we also imbricated the medial structures through our lateral approach. And so I would argue that getting away with using a 12 millimeter non-constrained posterior stabilized insert, and I can tell you that this patella tracked properly, and this is now a happy patient. He's about 8 months out. And so I would argue that this is the best way that you could actually approach this knee. So my summary of how I view these, essentially what is severe valgus? So if the valgus is less than 12 to 15 degrees correctable with intact bone, you can use any approach you're comfortable with, and I would probably use a medial approach for that. That's 95% of what I do for knee replacements. You'd probably be able to use either a cruciate retaining or a posterior stabilized implant. If you start to get above 15 degrees, to me that starts to become a severe deformity, particularly if it's fixed and if there's an attenuated medial collateral ligament. These almost always also come with lateral bone loss. So I would argue a lateral approach is a great direct way that lets you address all of these deformities. You'd probably need to have stems and augments, at least have them available. You start to think about a constrained insert, but most of these you could still get away with a posterior stabilized knee. If it's greater than 15 degrees and fixed, 20 degrees, 25 degrees is in the case I showed you, and the MCL is out, you'd probably want to start thinking about whether you need a hinge knee replacement for that. And again, it becomes a little bit easier in choosing whatever approach you want. Although even for that lateral approach to put that hinge knee is pretty straightforward. And I would argue it still addresses some of the deformities such as lateral patella maltracking.
What I'd like to do is talk about maximizing function in knee arthroplasty, and I think function is defined a bunch of different ways, and we'll try and run through what factors are important in maximizing function after surgery. These are my disclosures. I receive research support and consultant and royalties from Depew. Now, in the past, the bar was set fairly low. If you had a typical 70-year-old patient, if you got the knee straight, you got reasonable range of motion, the patient was happy and thought this is pretty good function for my total knee. But things are changing. We're seeing an evolving patient population that has changing patient demographics, changing patient expectations. They've had multiple prior procedures thanks to some of our sports medicine colleagues. They're also seeking interventions earlier because they're not happy with the loss of function, the increased pain that they're having at an earlier age. And you add to the fact that this article presented by Kurtz in 2007 outlined what the expected increase in knee replacement, roughly a 6-fold increase in knee replacement procedures over the next 15 to 20 years. And in fact, that has become reality as we start tracking out through 2013, 2014. So we're faced with this challenge. We're going to have ever more procedures that need to be done. We're going to have a shrinking surgeon base, particularly those interested in joint replacement. We have more demanding patients who are expecting better and more reliable outcomes. And so it's really incumbent upon us to develop implants techniques that are both reliable, user-friendly, and efficient to maximize our outcomes. And so when we look at outcome after knee replacement, there's several factors that are important, and certainly surgical technique. And what does this encompass? It encompasses the exposure, and Howard just elegantly showed us how to do this for a severe valgus knee. It also encompasses the alignment, component position, soft tissue balancing, all of which are related to surgeon experience and surgical technique. Certainly there's patient factors, which imply the motivation of the patient. How willing are they to work hard and get better? What sort of health issues or comorbidities may they have that will influence their outcome? And what is their BMI? And we're seeing an ever-increasing size of our patient population, and certainly this is going to have impact on function and outcome after knee replacement. Implant design can have an influence. Certainly surface geometry will influence the kinematics of the knee following surgery, as will the sizing of the implants influence soft tissue balancing and function and kinematics of that knee. Instruments clearly play an important role. The accuracy and reproducibility of the instruments influence the outcome. Are they user-friendly? Are they reproducible? And certainly we've seen this evolution from conventional instruments to computer-assisted surgery to patient-specific cutting guides to robotic surgery, all of which have a role in the future of knee replacement. And when we look at the success of knee replacement, it's easy to quote the figures, well, there's 90% success rate. And I think many of us tell our patients that's the case. We do over 600,000 knee replacements in the United States annually. And it's routinely believed that 90% of our patients are happy and would just go out and tell everybody about it and want to come back and have another one. And we often say survivorship is 90% at 10 to 15 years. But as you start to drill down in some of the literature, it was presented here in the British Journal in 2007, 10,000 patients using the registry from England and Wales were surveyed, and remarkably, they got an 87% response rate to their survey. And what they found is only 81% of the patients surveyed felt that they had a satisfactory outcome and or were happy with their result. And they found that continued pain was the best predictor of dissatisfaction. Another study published in 2010 looked at 1,700 patients and found that 81% of these patients were either satisfied or very satisfied, and 18% were either dissatisfied or unsure of the outcome. So certainly not the number that we've quoted throughout the years of 90% patient satisfaction. And again, pain was the biggest indicator. And so if we look back and study why are knees failing, why do we revise knees, particularly early on after the indexed arthroplasty? There's been several papers in the literature. This one out of the Rothman Clinic in 2002 looked at 212 revision knees. And they found that 56% of these were revised in less than 2 years. And when you study that, the majority of these people are being revised for instability of the implant early on. There's also stiffness, malposition, and malalignment, all of which are related to our surgical technique, all of which can lead to failure early on after arthroplasty. Another study out of Tom Fering's group in 2001 looked at 440 revision knees. 63% of these revisions were done in less than 5 years. Typical infection, but again, instability, a big player in this early revision factor. Now, when we look at this, we look at the lessons we've learned over the last couple of decades, and Howard was very kind with his introduction of me, but the reality is, we stand on the shoulders of those who came before us, and so this isn't something new. This is something that's evolved over the last 20, 30 years of knowledge. We've learned that instability is bad, particularly right after surgery, and instability can come in many forms. It can come in the coronal plane, the sagittal plane, but if you have knees looking like this post-operatively, this is a situation that's not going to be tolerable by the patient. We've also learned that alignment plays a significant role, as does sizing and implant positioning, all of which are encompassed in our surgical technique, all of which we have control over at the time of the index arthroplasty. But again, pictures like this are not typically consistent with happy patients in the early postoperative phase. So we ask ourselves, what is instability? And typically it's an abnormal motion, or in the case of a cruciate retaining knee or either a cruciate substituting knee, a anterior translation with flexion. So if you see a patient in a resting position with their knee flexed and the femur is sliding forward on the tibia, that's the opposite direction it was intended to go. And so often when you see a patient like this in clinic, right out of the gate, something's definitely wrong with regard to the balance of this knee. And so when we talk about flexion, mid-flexion instability, that's a term that's thrown around quite a bit. What are we talking about? And what we're talking about is this anterior paradoxical translation with flexion. The knee is meant to roll posteriorly with flexion, not anteriorly. And if we have intact ligaments, that's the case. And if we have a well-balanced total knee of appropriate geometry, that's the case. When it goes the opposite direction, a lot of bad things can happen. And usually this is associated with ligament laxity and improper soft tissue balancing, or perhaps not ideal implant geometry. And so when we look at function, and since Howard asked me to do this talk, I've asked all my patients I see every day, I said, what's function mean to you? Well, pain relief. How do we accomplish that? Well, certainly post-op pain management encompasses many things. Now, a lot of us would say, well, it's my approach, it's the implant I use, my technique, and I would say to you that probably has very little influence on the amount of post-operative pain. I think the biggest change we've seen over the last decade is the introduction and use of multimodal pain management. That is a single factor that I think has altered the recovery of the patients and how they feel and how they progress in the first week or two after surgery. Fixation, certainly, we need to get adequate fixation. It could be with cemented or cementless fixation. what is key is getting adequate fixation. I think as we evolve over the next 5 years with enhanced surfaces for fixation, we'll see the trend as we did with hips go from cemented to cementless fixation. Right now, the gold standard, I think, still remains cemented fixation. When we look at range of motion, what is adequate range of motion? Well, it depends on what you want to do. We know that for stair climbing, you have to bend your knee 83 degrees. For going downstairs, 90 degrees. Getting up from a chair, 93 degrees. Squatting, 140. And if you're kneeling or in prayer, 157 degrees. So what you want to do, what your goals are really going to dictate how much flexion is required. So what kind of influence does the patient have on this? Certainly we know from prior experience that pre-op range of motion is the single biggest determinant of post-op range of motion. Patient factors including their size, their diagnosis, how much prior surgery they've had, what kind of shape their soft tissue is going to influence the amount of range of motion. Certainly they're motivated. You can have a great patient with great soft tissue who's not motivated at all, and they'll get lousy range of motion. And we have limited ability to really significantly change the pre-op range of motion with therapy and exercises. They have what they have. What limits flexion when we look at the whole system? Well, certainly impingement. If we have impingement between the posterior femur and the tibia, that's going to limit flexion. And if we decrease the posterior condylar offset, that is the amount of offset of the posterior condyle, that will limit flexion. If we have paradoxical anterior translation of the femur in flexion, that will limit flexion. Retained posterior osteophytes and loss of posterior slope. So there's multiple factors we have control over that will limit flexion. And certainly from a surgical technique, if we maintain the amount of posterior condylar offset with our implant and our posterior bone resection, we'll be able to retain better flexion. There was a study published in 2002 that showed for every 1 millimeter loss of posterior condylar offset, there's an associated 6-degree loss of flexion for cruciate retaining knees. What about surgical technique? Balancing our knee, making sure that we're balanced throughout the arc of motion, particularly in flexion and extension, will enhance our ability to get better motion, have better stable range of motion. And to that end, removing posterior condylar osteophytes. Often we'll see a knee like this with large posterior osteophytes. If we do not remove those osteophytes intraoperatively, we'll get impingement by removing them, better chance for range of motion. And certainly the patellofemoral joint has influence. By maintaining proper patellar thickness and the overall patellofemoral height is important to range of motion. A study published in 2006 from Dick Scott's group showed that for every 2 millimeter increase in overall composite patellar thickness, there was a 3-degree loss of flexion. And in another study that same year, for every 2 millimeter anterior translation of our femoral component, there is an associated 2-degree loss of flexion. So the patellofemoral joint has an important role in amount of range of motion, and certainly, as Howard alluded to, proper tracking. If we fail to get proper tracking of our patellofemoral joint, we're going to have a difficult time obtaining a good outcome and or good range of motion. Now, what about implant design? Certainly, the goal for implant design is to allow some degree of posterior rollback. We all agree and acknowledge that you cannot obtain the same amount of posterior femoral rollback in a replaced knee as you can in a normal knee with 4 intact ligaments. It just is not going to happen. But we want to try and simulate some form of rollback to improve our chances for flexion. And associated with that, we want to maintain adequate contact area and deep flexion, accommodate increased tibiofemoral and patellofemoral loads that are associated with increased flexion. We want to avoid anterior soft tissue impingement and pain, which is often a source of frustration in patients. And in cruciate substituting knees, we want to avoid post-cam dissociation. So these are all factors we look to our implant to assist us with. And so when we look at the kinematics or motion of the knee, what kind of variables will affect how these two surfaces move across one another? Well, certainly the femoral J-curve plays an important role in how the knee is going to behave in flexion and how stable it will be throughout the arc of motion. The associated tibial geometry and how conforming or non-conforming it is to the femoral condyle and the femoral geometry. The amount of contact area is going to influence not only stability, but wear long term. The degree of femoral rollback will influence flexion. And certainly there's variations between cruciate retaining and cruciate substituting designs. So to summarize, as we look at gaining range of motion and stability, I think several factors are involved. Certainly the pre-op range of motion of the patient is going to influence our post-operative motion. Maintaining posterior condylar offset gives us a better chance of obtaining better flexion. Balancing our soft tissue and removing posterior condylar osteophytes will improve things. An implant that allows posterior rollback and maintains posterior rollback and avoids paradoxical anterior translation is helpful. And lastly, durability. How are we going to do that? Well, certainly we need to have stable initial and long-term fixation of our implants to bone. We need to have good soft tissue balance, which we should be able to control with our surgery. We need to have conforming geometry that's going to decrease interface stress. And we need to have an implant design that minimizes instability throughout the arc of motion and wear-resistant bearings. And I think we're moving in that direction with enhanced bearing designs. And does that mean we go back to monoblock to avoid micromotion between the implant and the insert? Or do we have modular locking mechanisms that are enhanced to avoid micromotion between the interfaces? And really, at the end of the day, improved function is all about getting most of these things right. Proper soft tissue tension, proper soft tissue balancing, an implant design that will facilitate all of the above, and surgical technique that takes advantages of both of those things. Thank you very much.